A new Surgeon General's report finds alcohol and drug misuse and severe substance use disorders, commonly called addiction, to be one of America's most pressing public health concerns. Nearly 21 million Americans, more than the number of people who have all cancers combined, suffer from substance use disorders.
Good afternoon. I'm Linda Frazier, and it's my pleasure to talk to you today about a topic that's very near and dear to me. As a nurse, health educator, and recovery advocate, I have over 30 years' experience in behavioral health, including adolescent and women's health, inpatient and outpatient mental health, and addiction treatment, particularly medication-assisted treatment. I am a survivor of sexual assault, and I am proud to say I come from a family in recovery. If you are watching Dr. Mack's slides, particularly the map, or the maps, you may have noticed, if you were looking at New England, that the state of Maine went from being green and slightly orange to being bright red between 2007 and 2014. In 2006, I worked in Maine, and my team and I were presenting and working with disturbing trend data indicating an increase in treatment admissions for young people 18 to 25 years old for opiate dependency. In 2006, not many people wanted to talk to us, and they weren't very interested in our concern about preventing increasing heroin or needle use in the state. So today, I am cautiously optimistic. Unlike 2006, we have people like yourselves that are engaged and eager to address this opiate epidemic. There is consensus on the need for access and for funding of such substance use disorder treatment services. And the recent release of the Surgeon General's report on alcohol, drugs, and health really will help build momentum to turn the tide. As providers, we need to be aware of the biological and socio-cultural differences that make women more vulnerable to the consequences of substance use. Services must integrate access to medications for treatment, effective cognitive, behavioral, and trauma-informed interventions, and be sensitive to women's distinctive and complex recovery support needs as they balance their roles as caregivers for children and families. Capacity to address a broad array of recovery support needs like care coordination, transportation, child care, peer recovery support, and safe housing are needed. And they're not only needed while in treatment, but in an ongoing way to support and sustain recovery. Smaller body mass and differences in metabolism, absorption, and elimination of medications and substances put women at increased risk for dependency and health consequences of the use over a shorter period of time. This accelerated process is sometimes called telescoping and means that women can have more severe opiate withdrawal and be at a higher risk for opiate overdose. Women are more likely than men to define themselves in terms of their relationships and their obligations, and they are strongly influenced by familial substance use. Initiation of substance use typically begins after introduction by a family member, close friend, peer, or an intimate partner. Histories of trauma, PTSD, and interpersonal violence are common among women and include rape, assault, and partner violence. Women are also more likely to have periods of problematic use of substances over their lifetime. And drug use is increasing among adolescent girls and women. Dr. Nora Volkov, the director of the National Institute of Drug Abuse, calls these trends among girls quite worrisome because between 12 and 17 years of age, girls have significantly higher rates of abuse of all psychotherapeutics, including opiates. And stimulant abuse is 60 to 70% higher among girls, and they have higher rates of ecstasy and inhalant use. Women and girls' pathways to use differ from men and boys. They are more likely to have co-occurring disorders and have higher rates of mood disorders like depression and anxiety. They may use substances to improve mood, relax, reduce stress, focus attention, gain energy, increase confidence, or even control weight. And women over 55 are the largest consumers of prescription drugs. Women are more likely than men to live longer, experience pain, and be prescribed addictive medications. Healthcare professionals frequently miss the signs of addiction in women and girls, who are more likely to receive long-term prescriptions for sedatives and analgesics for depression, anxiety, or other disorders. All of these factors underscore the importance of screening, brief intervention, and referral to treatment for girls and women. We also see gender differences in the experience of care reported by women. Social stigma, the demands of caring for young children or family members, fear of losing child custody can all delay women's entry into treatment. Histories of trauma, interpersonal violence, and the pressure to choose between treatment and relationship or family obligations also contribute to delays in seeking treatment, which means women have more acute stages of addiction and more serious health complications when they in fact get engaged in care. The risks for substance use and substance use disorders are best understood by looking at the cultural context of women's lives. Understanding cultural differences among women is vital to designing and implementing effective substance use disorders treatment services. Culturally responsive care improves short and long-term outcomes for women. The Substance Abuse and Mental Health Service Administration's Center for Substance Abuse Treatment has developed a comprehensive model of care for women that includes 5 core components of gender-responsive services. They address women's unique experience, they are trauma-informed, they use relational approaches, are comprehensive, and provide a safe and healing environment. Some women will also benefit from gender-specific services, which are services that only serve women. This comprehensive model also involves addressing the 6 fundamental principles of trauma-informed care. Building safety and trust requires a context where there is meaningful collaboration through shared power and decision-making. Women need a voice and a choice in their care decisions, and cultural, historical, and gender issues must be recognized and valued if they are to stay engaged in services. Many treatment interventions that have demonstrated effectiveness with males are also effective with women. However, treatment access, engagement, and retention among women improves when evidence-based practices are implemented with the specific needs of women in mind. For example, integrated approaches are important for women with co-occurring disorders, and programs like Seeking Safety, a cognitive behavioral approach for recovery from substance abuse and trauma, can be helpful, as can access to medication-assisted treatment and overdose prevention, or the use of Narcan, which may be important since women tend to delay getting help for a problem with substances and get help at later stages of the disease. It's called addiction. As in the management of other chronic conditions, treatment is important, but support in sustaining recovery is critical. SAMHSA also identifies 4 major areas that support recovery. These include health, home, purpose, and community. Recovery happens by building on small successes, and optimism and belief in women and girls' resiliency is key to hope and builds self-efficacy and success. When providers and recovering women are working together effectively, it is not only important to be clear, but also to be respectful. Language can disempower women, but it can also be used to empower them. Don Coyes says this best: if you want to care for something, you call it a flower. If you want to kill something, you call it a weed. So judgment and disrespect in terminology does not help with treatment engagement or patient activation. Creating a safe environment requires attention to both language and nonverbal communication. Use a motivational rather than a confrontational approach. At the heart of motivational techniques is unconditional positive regard. So, for example, team training on focusing on women's strengths and coping strategies and on sensitivity and awareness of the needs to use neutral, non-threatening language and postures can be critical to working with anyone with trauma. Trauma can also lead to hyperarousal, and the appearance of threatening behavior by staff can jeopardize stabilization and lead to clients leaving services against medical advice. Improving outcomes for women with opioid dependency and their families requires providing a full continuum of services and recovery supports, including improved screening for substance use disorders, access to medications, and implementation of gender-responsive, trauma-informed services. Thank you.
Hi, Grant Baldwin Injury Center. Thanks for a suite of really fantastic presentations. I have a couple of questions. My first is both for either Mishka or Linda. I wonder if you could comment, Mishka, you sort of highlighted the successes that were happening in Baltimore, sort of telescoping out. I wonder if you could comment on if there's a state writ large that you think is doing these integrated holistic services best. But, Linda, maybe you want to answer that as well. And then my second question is, you made a very compelling argument about the real opportunities that exist in the current ACA law around receiving these integrated services. As we as a country wrestle with where we are with administration change, I wonder if you could comment on sort of the realities at play and how we hold on to what's valued, such as integration.
So at risk of being criticized for this, I recently moved to Massachusetts, and I have to say, with the advent of Romney Care, which predated the ACA, I think Massachusetts has a leg up on looking at how to integrate services across the spectrum, as well as what they're doing in terms of integration of substance use disorders and mental health treatment and access to MAT. They are by no means the only state that's successfully working on this. It would be unfair of me to say they're the only state that's doing this well, but they're the one I'm the most familiar with at the moment. I think every American needs to think about what we're about to embark on. And I don't want to take a political stance on this, but I can tell you that I'm concerned about anything that would change parity or access that my family members have to health care that they did not have before ACA. That's a personal statement, but I think it's an important personal statement. This is not health care access for others out there. This is us. And so I don't know what the answers are. I think many states have approached this very differently. Some states have expanded Medicaid, some haven't. We've learned a lot, and we need to think carefully about how we proceed.
The only thing I would add to that is that one of the consequences of the opioid epidemic has been a huge amount of attention to substance use disorders in society, and that's attention's not going to go away with changes in federal policy per se. In fact, during the election campaign, every single candidate, Republican or Democrat, all had at least one statement in which they acknowledged addiction as a disease. And having worked with people on, all sides of the legislature, I can say that I feel that I just moved to Virginia, and I feel that there, like, everybody gets parts of this. And I think it's focusing on the comprehensive model on care, on the life course piece of it, and really thinking about what the role states have in terms of legislating healthcare related policy. And there's lots of examples of good policy out there too.